Welcome to the Next Learning in 10 series. I'm Jasmine, one of the registrars with the Department of Infectious Diseases at Singapore General Hospital, and will bring you through the topic of pneumocystis infections today. So for today's topic, it is important to understand that pneumocystis infections occur in the immunocompromised host. If untreated, this condition is potentially life-threatening. We'll also bring you through the microbiology, the epidemiology, and the pathogenesis of pneumocystis infections. And this will help you recognize and diagnose pneumocystis infections and to treat such patients appropriately. The outline again will be covering the epidemiology, pathogenesis, clinical presentation. We'll go through the workup of patients with pneumocystis infections, run through the natural history, complications, and treatment of our patients, as well as reminding us the importance of prophylaxis in certain immunocompromised hosts. The causative organism for pneumocystis infections is Pneumocystis jirovecii. It was previously called Pneumocystis carinii, but Pneumocystis carinii today refers to pneumocystis infections occurring in rodents. What is it? It is actually a fungal infection, and this fungus also shares close biological characteristics with the protozoa. Importantly, it lacks ergosterol in its plasma membranes, and hence, fungal treatment will not work for pneumocystis infections. The fluconazole is not going to work. Where is it found? It's ubiquitous, it's found in our environment, and frequently it's spread via airborne. Who gets it? The immunocompromised host, as highlighted earlier. Reviewing the epidemiology of pneumocystis infections, some observations first. As highlighted earlier, it occurs in immunocompromised hosts. In malnourished and premature infants in Europe following World War II, it has been described. They are also described in patients with hematological malignancies, and this was reported heavily in the 1960s to the 1970s. Following the HIV epidemic in the 1980s, the prevalence of pneumocystis infections have also increased, especially in patients with AIDS. And for most people, we are all colonized with pneumocystis, but we do not necessarily get the infection. Focusing on the HIV population, PCP occurs in 70 to 80% of patients with AIDS. The risk factors in this group of patients is if their CD4 count is less than 200, their CD4 cell percentage is less than 14%, or if they have higher plasma HIV RNA levels. Previous episodes of PCP, the presence of oral thrush, recurrent bacterial pneumonia, unintentional weight loss are also risk factors for PCP development in HIV patients, and the incidence decreased with the introduction of antiretroviral therapy, again highlighting the fact that PCP or pneumocystis infections occurs in the immunocompromised host. For the pathogenesis of pneumocystis infections, we look at the normal host response in response to Pneumocystis jirovecii first. This is a pictorial representation of the organism. It's airborne. We find it in the alveolar air spaces, and in response to this organism, the macrophages are activated to remove the pneumocystis infection. In the presence of underlying immune dysfunction, be it T-cell defect or B-cell dysfunction, there's also macrophage dysfunction. The pneumocystis accumulates in the alveolar air spaces. As the load increases, patients may complain of breathlessness, and this is a picture of their chest X-ray. They present with bilateral hilar infiltrates. Pneumocystis infections mainly manifest as pneumonia. Extrapulmonary disease may occur, but they often occur in severe immunocompromised states, especially in the HIV patients. The actual incidence of extrapulmonary disease is unclear, and it often presents as multisystem disease. It's often found at autopsy, and the sites that could potentially be involved are the lymph nodes, the spleen, the liver, the bone marrow, the gastrointestinal tract, the eyes, thyroid, adrenal glands, or the kidneys. For this diagnosis to be made, often it's a histopathological diagnosis, where there are areas of necrosis with foamy material found. On Gamorre methenamine silver stains, you can see the pneumocystis infections, or based on fluorescent monoclonal antibody studies, the diagnosis of extrapulmonary pneumocystis infections is made. We highlighted again and again that pneumocystis infections occur in immunocompromised hosts, be it HIV patients or non-HIV patients. For the non-HIV patients, often they are heavily steroided. They may also have underlying hematological disorders. The history will give you a clue, and often the suspicion of PCP is made based on history. The defining statement when they give the history is that there's progressive dyspnea associated with non-productive cough, and they may have fever, and the key things to think about would be exertional symptoms. They may or may not have chest pain. On examination, patients may desaturate either at rest or on exertion, and if again they do desaturate on exertion, it is highly suggestive of PCP infections in the appropriate host. They may be tachycardic, tachypnic, or dyspneic. And on chest auscultation, the lungs are often clear. We need to look for complications of PCP infections, especially in patients who have been untreated for a long time. They are very breathless. Look for evidence of pneumothorax, and in the HIV patients, also beware of co-infections. They may also have coexisting infections like tuberculosis. In terms of the workup for our patients, for the biomarkers, the LDH may be elevated. This again is non-specific. Remember to complete the septic workup because co-infections with either bacterial pneumonias, bacteremias, or TB may be present. Perform the full septic workup and assess the patient's oxygenation. Document the baseline arterial blood gases. For radioimaging, as mentioned earlier on chest X-ray, there's diffuse bilateral infiltrates extending from the perihilar region, and on HRCT, often you see bilateral ground glass infiltrates. You may or may not find pneumatoceles present depending on the severity and the chronicity of the condition. Often we would ask for the bronchoalveolar lavage or ask for induced sputum looking at the Gamssia stain, which may clinch the diagnosis of pneumocystis infections. We look at the natural history and prognosis of patients with pneumocystis infections. If pneumocystis infection remains untreated, patients develop progressive respiratory failure and death. What would predict mortality risk in such patients? These are the following. If patients are hypoxic at time of presentation, with a PaO2 of less than 70 mm mercury on room air, if they have a history of recurrent pneumocystis infections, if they have anemic, if they're elderly, with multiple medical comorbidities, or if in the HIV patients they have pulmonary Kaposi sarcoma, these factors predict for mortality. Other poor prognostic factors include extensive infiltrates on chest X-ray, the presence of interstitial edema and fibrosis at biopsy, or hypoalbuminemia. In patients who are treated for PCP, these are the following survival rates. For HIV patients, before antiretroviral therapy was instituted, survival rates were dismal 34%. However, after administration of antiretroviral therapy, survival rates increased to 71%. For the non-HIV patients, survival rates are 30 to 50%. Common complications of pneumocystis infections include the following. Patients develop respiratory failure. Pneumatoceles may develop, and if they burst, it may result in pneumothorax or pneumomediastinum, and watch for subcutaneous emphysema. In the chest X-ray on the right, there is air lucency along the left heart border, and this is pneumomediastinum in a patient with severe PCP who is intubated, showing that she has respiratory failure. She is in acute respiratory distress syndrome, and the pneumomediastinum developed a week after she had PCP treatment. The drug of choice in the treatment of pneumocystis infections is Bactrim. Other agents may be used. Clindamycin and primaquine is often used as salvage therapy. In patients who cannot tolerate Bactrim, IV pentamidine is used for severe disease, and atovaquone suspension is only used for mild to moderate disease in patients who cannot tolerate Bactrim. Treatment duration is 21 days for HIV patients, but 14 days for the non-HIV patients. Add on to the treatment of pneumocystis infections, apart from instituting appropriate antimicrobial therapy immediately, you need to think about the use of adjunctive corticosteroids, and this is indicated if within 72 hours of PCP treatment, patients are hypoxic on room air, or if the AA gradient is more than 35 mm mercury within 72 hours of starting treatment. Treatment failure does occur. Sometimes patients cannot tolerate the antimicrobial agents used, and if there is lack of improvement in respiratory function despite 4 to 8 days of therapy, perhaps treatment has failed. But remember, before you comment that there's treatment failure, you need to make sure that you have treated the patient effectively for co-infections which may exist with pneumocystis infections. Moving on from treatment, we must prevent PCP in the appropriate patients in the appropriate host. We talked about immunocompromised states, and this can happen in HIV patients or non-HIV patients. We have to immune reconstitute our patients where appropriate. For HIV patients, it's through the initiation of antiretroviral therapy. For the non-HIV patients, remember to reduce or stop immunosuppressions as appropriate to prevent PCP infections. For primary or secondary PCP prophylaxis, the antimicrobial agents which you could use include Bactrim, which by far is the most common. If they can't tolerate Bactrim because of drug allergies, rashes, consider the use of other agents. You could use either nebulized pentamidine, Dapsone, or Dapsone with pyrimethamine and leucovorin in patients with HIV, and this would protect against toxoplasmosis as well, or the use of atovaquone. For the HIV patients, stop prophylaxis when the CD4 count is more than 200 for more than 3 months consecutively. In summary, PCP occurs in immunocompromised hosts. It is life-threatening, requires prompt recognition and treatment. Evaluation requires documentation of the patient's immune status, respiratory function, and oxygenation at time of presentation. In treating patients with PCP infections, remember, they get worse before they get better. Management includes, first, treatment of the acute infection. Bactrim is the drug of choice. If they are hypoxic at time of presentation, remember to include steroids and to rule out other opportunistic infections. Second, immune reconstitute our patients as appropriate, and following treatment of acute PCP, remember you have to prevent PCP as well. These again are our key references. Special thanks to Dr. Jenny Low, who has allowed me to be part of this Learning in 10 series. Thanks to Florida Center for Instructional Technology for use of graphics. And thank you for your time and attention.